My name is Charl Els and I'm a clinical professor in the Department of Psychiatry, and I'm appointed as a physician educator in the Division of Preventive Medicine, Department of Medicine at the University of Alberta. This session focuses on the occupational impact of therapeutic drugs. Thank you to the Workers' Compensation Board of Alberta for making funding available for this project. There are no conflicts of interest to declare, and the opinions expressed in this presentation reflect those of the speaker and not necessarily those of any collaborator or funding agency. At the end of the session, participants will be equipped to classify therapeutic drugs on the basis of occupational impact. Medications are frequently prescribed for medical conditions that may impact fitness to work, especially in safety-sensitive positions. Not only can the underlying medical condition for which medication is used impact occupational capacity and risk, but also the very medication that's used to treat such condition may adversely impact risk. Medications may impact several domains of a person's mental status, including cognitive, mood, anxiety, and other domains. Some medications may gradually result in impairment, while others may result in a more sudden incapacitation. The American College of Occupational and Environmental Medicine, or ACOM, developed a guide published by the Reed Group, which provides information on a large number of medications and how to view such in terms of its impact on work. We use this guide in other settings, and in this case for safety-sensitive workers. And the application of this is not to suggest any endorsement by ACOM, but rather suggesting the utilization of an existing framework to augment broader occupational practice. The guideline places medications in one of 5 classes, as follows. The first consideration is that of diagnosis, to which the letter D is assigned. In other words, this may require an evaluation to determine if the diagnosis constitutes a medical basis for limitations or restrictions and accommodations. For example, in cases of moderate to severe major depressive disorder, or MDD, persons suffering from MDD are substantially more likely to report high levels of work impairment due to the common symptoms of depression, including cognitive, behavioral, motor, and social impairments that may impact occupational capacity and risk. Also associated in the resultant impairment associated with MDD are symptoms like irritability, angry outbursts, isolation from co-workers, causing impaired cooperation and communication. And all of these can, of course, foreseeably impact capacity and risk. And in all cases of evaluating therapeutic drugs, the impact of the actual underlying diagnosis needs to be considered in addition to the medication. The second designation, now focusing on the medications, is that of R, standing for restricted. And this is reserved for medications that are proven to have an impairing effect. Examples would be medically authorized cannabis, benzodiazepines, opioids in safety-sensitive positions, and several other medications. Usually, this impairing medication would prompt the initiation of restrictions to mitigate risk, or alternative medications for the treatment of the condition should be considered. The next category is that of temporary, to which the letter T is assigned. This is for medications that have an effect early on, that being at the beginning of treatment, where the effects are expected to eventually dissipate and any risk should be mitigated. This would trigger temporary restrictions until it's reasonable to assume that the effects of the medication are no longer posing a risk of occupational impairment. An example would be some antidepressants. Many different classes of medication, also the antipsychotics, stimulants, and others would warrant temporary restrictions early on, but are subsequently considered no longer necessary and acceptable without permanent restrictions. If impairment is anticipated to be or is observed to be prolonged, usually allocating restricted R designation, as discussed earlier, would be appropriate. And that refers to the occupational restriction whereby the person on this particular kind of medication is precluded from certain job or task in order to mitigate risk. Alternatively, the person is switched to a different class of medication. The next designation would be that of S for shift. These medications are known to have effects of short duration that may adversely impact the worker's ability to perform functions. And these medications may be taken while the safety-sensitive worker is off duty, provided there's adequate time for washout before returning to duty in order for the resolution of any effects that would be adversely impacting performance to be addressed. The half-life of the drug determines the duration of the washout time that is needed, and the goal is certainly not to solely rely on the subjective information of the person taking the substance to determine if he or she feels that he or she is no longer impaired, but rather to look at the actual half-life of the compound in order to provide a reasonable estimation of what would be considered the appropriate washout time. Examples here include short-acting compounds like hypnotics that are not associated with carryover effects and that don't belong in the restricted class, as well as sedating antidepressants like mirtazapine and trazodone. The next category is that of A or acceptable. Consumption of these medications are unlikely to adversely impact performance of safety-sensitive job functions. And it's for this reason that they're generally deemed acceptable for use while on duty, even in safety-sensitive settings. Examples here would include some of the antidepressants, for example, the SSRIs. It remains prudent to have a very high degree of sensitivity to the potential impact of medications that are newly introduced, especially medications that are psychotropic, and especially early in treatment. For the class of medications like psychotropics medications, as is the case for many others, the diagnosis may dictate restrictions has to be taken into consideration. Some drugs impact occupational capacity or risk only early on in treatment, while others warrant ongoing, more permanent restrictions if alternative options are not available. The diagnosis of the condition for which the medication is used should be considered, and in summary, both the presence of a mental health condition as well as the medication for which it's treated may impact capacity and risk. The ACOM guideline offers a useful classification that includes one of 5 classes: A, acceptable; R, restricted; S, shift; T, temporary; and finally D for diagnosis. There's of course the expectation of ongoing monitoring, iterative assessment, and for offering treatment for related adverse effects that may impact occupational capacity and risk. We've included a brief list of references that may be helpful, and we refer you to the LEO guideline, the ACOM LEO guideline, where the classification is described. Looking forward to your feedback and comments, and please help us identify future topics for discussion. Thank you.